Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Dr. Christopher Netzel is board certified in pain medicine and anesthesiology, practicing at Coastal Health Specialty Care in Jacksonville, Florida. His medical residency in anesthesiology was completed at University of Wisconsin Hospitals and Clinics in Madison. Dr. Netzel is a member of a number of medical associations, including the North American Neuromodulation Society, the American Society of Anesthesiologists, and the Wisconsin Medical Society. Dr. Netzel utilizes whole food, low-carbohydrate, healthy fat, and ketogenic diets as a component of a multidisciplinary approach to address metabolic syndrome within the context of chronic pain. Through this approach, improvements in many types of pain have been observed, likely due to weight control, decreased inflammation, enhanced glycemic control, and potentially improved neuronal function. Furthermore, Dr. Netzel has successfully assisted patients in reducing or ceasing their usage of diabetic and hypertensive medications, achieving better sleep quality, experiencing reduced heartburn, and overall enhanced well-being. Dr. Christopher Netzel, what an absolute honor it is to welcome you to Boundless Body Radio.
Thank you. I'm happy to be here.
It's such an honor to have you. You cover diet in such an interesting way and integrate it into what you do. I think it's absolutely fascinating. I love that you spent a lot of time in Wisconsin and now you're someplace much warmer. How is the weather in Florida compared to Wisconsin?
Beautiful. I don't miss shoveling snow. I don't miss, 7 months of gray and cold. That's for sure.
Man, that's great. Dude, I'm in Salt Lake City in Utah and it is May, early May. I had to shovel snow this week at my house. I don't live at ski resorts. I live in the valley and it snowed in the first week of May, man. It's just starting to warm up now, but I'm very, very jealous.
Yeah, we're a cool 92 degrees today. It's beautiful.
Very nice. I love that. I will tell you this. My wife's family kind of has a cabin up in the northern part of Wisconsin. It's a little place called Crandon, which is absolutely beautiful. The bugs there are absolutely legit. When people tell you that the bugs are bad in the summertime, take them seriously. I didn't. But the cheese that you can find, unfreaking believable. You must miss that a little bit.
A little bit. We've still got some relatives that live up there, so whenever we visit or when they come down here, they bring us some stuff.
Good.
And, we get a bit of a taste of it again.
Good. Stock up when you can. That's great.
Right.
Super interesting. So heading into this episode, I thought I kind of knew what a pain doctor did. And essentially I just kind of thought it's like you're throwing out, pharmaceuticals to people, a lot of narcotics and things like that. Maybe not narcotics, but just heavier kind of pain medications. And learning about you and your work has really opened up kind of my eyes as to what pain medicine actually is. So in your words, what do you do and how do you practice medicine?
Yeah, so I am an interventional pain physician, and so I am pretty broad spectrum. I have been classically trained in how to manage chronic pain from a number of perspectives. Yes, everybody thinks about is medications. I mostly try to utilize non-opiate strategies. I try to minimize or avoid those if possible. I'm a proceduralist, and so I do injections or advanced procedures, ablations, and implantable devices and other minimally invasive techniques to manage pain. But and I incorporate things like physical therapy, and I try to get people plugged in with other resources like chiropractic and acupuncture and psychotherapy and all these things. As I got into my practice, however, I started to become more interested in the nutritional element. A lot of people know this now, but as a medical student, we don't get any training in nutrition, and what we do get is the typical dogma that we've been given for a long time that, quite frankly, to me, hasn't really worked. Just like most people in my position, I think in this space, I came to this through my own journey. I came out of my own training and fellowship after my residency. I was 40, 45 pounds overweight. I was, didn't have very much energy. I wasn't sleeping well. I had joint aches and pains. I was sort of depressed. And I stumbled across, I don't even know who it was originally. It might have been Gary Taubes. I can't remember exactly. Then I started to go down this rabbit hole and started to notice improvements in my own health using some of these strategies. And then simultaneously, I was seeing patients in my clinic who were struggling with these things and they weren't getting good advice. They were, they maybe needed a knee surgery, but they were, 100 pounds overweight. And the knee surgeon would say, well, let me know when when you lose 100 pounds and we'll do this for you, but didn't give them any help with it. Right. And so slowly I started to educate myself more. And then the pandemic hit, and it gave me a whole lot of free time. And so I started to actually get formal training through the Nutrition Network, as well as the Society of Metabolic Health Practitioners. And I actually did all the CME to be obesity medicine certified. I just never took the exam. Honestly, because I didn't really see a need to by the end of it. And so I started utilizing this stuff in my practice more and more, and started seeing people get better. I was able to take people off some of their diabetic medications or reduce them. I see people come off their their blood pressure medications somewhat regularly. Their weight improves. And you got to remember, my patients don't have the ability to exercise very much. It hurts. So they're limited in terms of what they can do. So eating less and exercising more doesn't really work for them. And in the process of them improving some of these things, they started to tell me their pain got better in some ways, or they were able to do more. And, that totally flipped a switch in my mind about how I wanted to practice medicine. So, I always make sure people know that this is what I do is not a panacea, meaning it's not going to be a cure-all. It's not meant to, I don't want to overpromise or overstate what this can do for people, but it can help the vast majority of my patients, in my mind, in a way that doesn't involve pills or injections or surgeries or something more invasive. And so that's, a bit of a long-winded answer for, that's how I think about this.
Wow, that's amazing. As you look back on witnessing some of the other doctors in this field tell people they need to lose 100 pounds, how many times did you see the patient go, "Oh, I need to lose 100 pounds? Oh, got it. I had no idea. I'll just go out and do that right now. Like, thank you, doctor." Like, was that ever a response?
Yeah. I mean, the response was usually like anger or depression, or they were just like, they gave up. And, they would get referred to a bariatric surgeon maybe. And there's a place for that. I'm not going to say that there's not, but in my mind, if you have that done and you don't address the dietary piece, you're just going to set yourself up for failure later on. I've actually had some people suggest that if they're on the cusp, like on the border of needing, qualifying for bariatric surgery, I've had some people encourage them to gain weight in order to get to that threshold. And so I just looked at this and I said, this is kind of crazy. We can do better. But again, we are not trained that way. Even the bariatric folks sometimes aren't trained that way. And so it took a little bit of a reorientation in my mind.
Yeah. Okay. Well, thank you. And I want to clarify that point as well. In no way are we trying to blame any of the doctors in the industry. You're trained in what you're trained in. If you didn't get the information, of course, you're not going to have a better answer. So in your mind, as you go back to when you were, kind of discovering low carbohydrate at the time, what did you think about being healthy or eating healthy? Was that part of your consciousness that you should eat healthy and that might help with pain, or was that just completely off the table?
I didn't really pay it much thought until, I started to notice it in myself, right? I've had both of my ACLs have been reconstructed from, injuries in my college years. And I was, I just felt like an old man. I was, having knee soreness in the morning, and, I felt swollen and all these things. And I started to notice that lift. And so that was the beginning of it. And then as I went down the rabbit hole with this sort of thing, you start to realize, okay, well, a low carbohydrate or ketogenic approach was utilized for seizure treatment many years ago and still is today. That's 100 years that it's been used for that reason. And I mean, so many of the nerve pain or pain medications in general that we use are seizure drugs. And so, you start to connect the dots with that. And then you find out that, people with diabetes or metabolic syndrome have consistently elevated inflammatory markers. And so all chronic pain is in some way inflammation, in some way nerve dysfunction, some combination of those things, among others. And, if I've got an intervention like low carbohydrate diets that will improve the components of metabolic syndrome without exception, and is a seizure treatment, why wouldn't that help with chronic pain, or at least give people a chance to, again, there's no guarantees. I think of things in probabilities in terms of, what can I do to increase somebody's probability or odds that they're going to feel better? And I think that's what this does for the vast majority of people that I see.
Vast majority. Yeah. I mean, it's pretty low hanging fruit if you can get somebody to want to do it. Obviously, it involves a lot of behavior change, and we can talk about that as well. But going back to your own personal story, what kind of trepidation did you have? I mean, what little nutrition education you got, through the years, what were some of the things that concerned you? Were you worried about things like cholesterol or, eating tons of fat in the diet? Like what concerned you?
Honestly, at that point, I think I had already started to realize the things that we had been given to understand for a long time were not true. I mean, I had done the low fat, the low calorie, fasting to a degree. I wasn't really fasting like like we think about it now, but exercising myself to death, which only gets harder as you get older. And I had all those things in the back of my mind. I had tried vegan for a little while. I had done so many different things. And I didn't really think about the consequences because I was seeing so many benefits in front of my eyes. I mean, the first 4 months that I did this, I dropped 20 pounds without even touching the gym once, and I wasn't even time restricted eating. I wasn't doing any of that. That just came more naturally as I was like, well, I'm not hungry in the morning. I don't need to eat unless I'm, feeling like I need to. And so, I was seeing all these benefits, and I later start to go down the rabbit hole of like, well, what is the cholesterol situation? As my patients would ask me about it. And I started to make sure I educated myself a little bit more. I'm not a lipidologist by any means, but I've got a decent handle on it after all of the research I've done.
Yeah.
So.
Gotcha. So that kind of came later. So from where you are today, since this topic is so hot and everybody's talking about it, we just talked to Dave Feldman on the show. Would you be worried about somebody coming in as that kind of lean mass hyperresponder phenotype where, they have very low triglycerides, very high HDL, and also have very high LDL? From where you are now, again, not medical advice, you're not a lipidologist. From what you understand about it, would you be concerned?
No. No, I don't think so. I don't think we have any evidence to say that. Dave Feldman, I consider him the expert in this. I just listened to a podcast he was on yesterday. The way I think about this, and he talks about this very eloquently in one of the talks he did. If you look at the Framingham data, which is the largest longitudinal data set that we have for heart disease in this country, mostly men, unfortunately, but anyway, if you look at that data and specify the things that you mentioned: low triglycerides, high or normal HDL, no weight problems, no hypertension, and no diabetes or prediabetes, your total and LDL cholesterol doesn't matter in terms of your heart disease risk. And that's what he's finding out with the most recent study he did, Dave Feldman, with lean mass hyperresponders compared to people with familial hypercholesterolemia. It seems like neither of those groups have substantial plaque burden when it comes to their coronary arteries, and the plaque burden that they may have does not have any correlation to LDL cholesterol. So the way I conceptualize this is we have a list of risk factors that are much, much more predictive of heart disease. So smoking, right? Far and away, probably the number one. And then after that, you've got diabetes. And then following those things, obesity and hypertension. And then when you look at the cholesterol numbers, triglycerides and HDL, LDL cholesterol is way down that list. And so I look at it like, why focus on this one relatively small risk factor that doesn't have a very strong association if all these other things are much more important? And the vast majority of my patients have many of those other things. So it's almost like missing the forest for the trees to me. Now, I saw a patient the other day who we've been working on things. She hasn't really committed fully to what I want her to do. And she doesn't have diabetes, but she's hypertensive. She's got a little bit of weight concerns, and her triglycerides are 150-ish, and her HDL is 46, let's say. And her LDL is 250. And I said, all right, here's your choices. We can keep working on this stuff, and I guarantee we'll get your triglycerides down. Your HDL will be as good or better than it is now. We'll get your weight in a better place, maybe get you off your blood pressure drugs. But if you don't do that, then you probably have to take a statin. right? Because if you're not addressing these other risk factors, yeah, you probably have to do something to reduce your risk, which there may be some evidence for those statin medications in that case. And so everything's individual, right? No patient, no two patients are the same. And I definitely don't tell them to do anything without consulting their primary and doing their own research. Because at the end of the day, I'm not a cardiologist. But I think that if we're overly worried about this LDL total cholesterol problem when we've got bigger fish to fry.
Yeah. Not a cardiologist, but pretty decent explanation there. Very good.
Yeah. And Dave Feldman does so much better than I can, but most of his thoughts on this, I think, are on the money. And I think it's much, much more complicated than LDL cholesterol. You know, I use the analogy, worrying about LDL cholesterol is sort of like blaming the spackle for whatever put holes in your drywall, in my mind, where what happens typically is, my understanding is, the body, the blood vessels in the heart will get damaged from something, smoking, diabetes, high blood pressure, whatever. And it has to come back and kind of fix those damages. And part of that is some platelets and white blood cells, but also cholesterol, among other things.
Yeah.
And so the answer to that problem is not using less spackle, reducing your LDL cholesterol. The answer to that problem is stop putting holes in your drywall.
Yeah.
Right. So that maybe that's not the best analogy, but it's the best I got.
Pretty darn good. I really appreciate that. Yeah, I was just at Dave's conference a few months ago, the Collaborative Science Conference in Las Vegas, and the thing that really stood out as we were going over some of the numbers and the data and talking a lot about this kind of phenotype and LDL is how predictive the model is. Like, you can hear somebody's stats and almost in your head, like, kind of think like, oh, I'll bet this guy's LDL cholesterol is going to be X. And sure enough, like, you're kind of close a lot of the time. It's very predictive and just seems that like the evidence is just getting stronger and stronger all the time.
Yeah. And, you know, from a pain standpoint, the way I talk about this is the statin drugs contribute to a number of side effects in many patients, and it's higher than we realize for a number of reasons. But I mean, a good proportion of my patients get muscle aches and pains, joint aches and pains. It can contribute to liver dysfunction, cognitive decline. You know, it turns out our brains need LDL cholesterol to transport cholesterol and fats to it to repair itself. Our brain and our nervous system is substantially composed of cholesterol and fat. Ironically, statin drugs contribute to the development of insulin resistance in some patients, which I find ironic because that is a much bigger risk factor for heart disease than LDL cholesterol is. And so I make sure patients know that risk. And I've seen some people, they come off the statin and their knee feels better or their back feels better because they don't have as much muscle pain. So I'm careful about that. Like I say, I make sure that we're trying to reduce every other risk factor that we can while we do that. But it may be a contributor to problems for people.
I don't think we talk about that enough. I don't think enough people understand the impact of these side effects. And everybody knows that there's side effects, but there's sometimes you don't realize the impact of some of these things and how it really merits you to like sit down and really think like, do I want to take this and hopefully have this one thing that has really weak evidence and hope that that helps me versus all these other things that are like day-to-day quality of life stuff. Like, I don't think we talk about that enough. That's really important. The cognitive decline piece alone is huge.
Right. Yeah. And you're right. The evidence for primary prevention for the statins is not very good. You know, if you're trying to prevent a heart attack the first time around, the data is something like the number needed to treat, meaning the amount of patients I have to treat in order for one patient to benefit from a statin drug is something around 100. So just about 1% of patients will get some sort of benefit. And typically that benefit, magnitude of that benefit, if you look at the data closely, is a month or two you delay a heart attack by. And so, again, that's not everybody, but that's just the averages, the way that I understand them. And, you know, meanwhile, you've got this propensity for side effects.
Yeah, that number needed to treat is so important to talk about as well. I've heard numbers all the way up to like 229 or something, like much higher than that. And at this conference, there was a cardiologist who was arguing like, no, it's much better than that. We think the number in certain situations is closer to 1 in 24. And that's a much better number for sure. But when you think about that, like the point that I made is like, okay, great. Let me grab this guy after he's done talking. Let me see if I can borrow $100 and take it to the craps table out of the casino, out of the conference center, and place a bet on a 1 in 24 probability. Do you think you'd be willing to do that?
Right.
Like, you really need to think about those things.
Yeah, and if you think about that, that's still a 4% responder rate. It's not very good. And so a couple of things. The other part about that data is that many of my patients are on like low dose statins, so they're on atorvastatin 10 or some other low dose statin drug, and most of the studies on statins have been on high dose statins, so atorvastatin or Lipitor 80 milligrams. And so if there's a dose response to this, the low dose statins are even less likely to help somebody. So again, I don't want to get out of my lane with this. And I'm not trying to say LDL cholesterol means nothing at all. However, I think that we've overemphasized it at the expense of some of these other things. And at the expense of side effects.
Yeah, I appreciate that. And the work of Dr. Nick Norwitz is proving that there's other things you could include in your diet, including Oreos, that might drop your cholesterol way more than a powerful, strong statin. I love that he is kind of pushing that message along in that way, not telling people to eat Oreos, but just showing that this is the mechanism and it's matching the things that Dave Feldman has been talking about for all these years. So I appreciate that. I understand it's not really in your league, but I think statins are really important to talk about and all those side effects, including pain. And as we're getting back to the topic of pain, I don't think many people make the connection between diet and pain. So let's kind of go there next. Like, how, in your opinion, how is the diet linked to increasing or decreasing pain?
Yeah, so there's a lot of ways that I think this happens. I get patients that come in a couple of varieties. I got some that have, definitive structural problems, whether it's, pinched nerves in their spine, terrible knee arthritis with no, joint space left, or hip or shoulder, rotator cuff problems, whatever. And so I think of that sort of like a fire burning in their body almost. And having poor diet and usually some components of metabolic syndrome, right? Insulin resistance, diabetes, hypertension, all the things that we've talked about, it's like akin to somebody throwing gas on that fire. And so if, yes, we can do some things about the structural problems, right? I can do things for pinched nerves in your spine. I can do things to help the pain in your knee. But if we can just stop throwing gas on the fire, you're going to feel better without me touching you with a needle, without me giving you a pill. And in fact, we might get you on less pills. And so, I think there's a couple of mechanisms behind which, dietary influences affect pain. Inflammation is the first one that I talk about. Consistently, people with metabolic syndrome especially have high inflammatory markers. And if you improve that, especially with a low carbohydrate approach, those come down. Nerve function, like we talked about, all chronic pain is in some form nerve hypersensitivity, which happens over time. If we can stabilize nervous system tissue by either stabilizing its signaling in the form of almost like a seizure treatment, there's really good evidence coming out now that improving mitochondrial function by improving energy utilization in the nervous system tissue is one of the mechanisms that nerve function improves, especially in the brain. Improving those things can improve the experience of pain. Weight, we talked a little bit about weight. Mechanically, if you've got a knee problem and you're 60, 70 pounds overweight, we know that 1 pound of weight lost or gained is about 4 to 5 pounds of strain off of those joints. And then, you get into the more esoteric things like mood or mental health. So chronic pain and mental health disorders are inextricably linked. So many of my patients will suffer from depression or anxiety. And if you improve one of those things, the other will improve. Meaning, if somebody suffers from depression and I improve their pain, sometimes their depression gets better. But if I improve their depression, sometimes their pain gets better. And what's interesting about the dietary strategies, low carbohydrate, carnivore, coming out of Dr. Georgia Eads' work, is that it affects both. Meaning, we can improve your mental state, depression, anxiety, schizophrenia, bipolar disorder, and simultaneously also improve the experience of pain from the other side. And so I think there's tremendous power in that. in a way that, again, doesn't involve um, risk very much.
Yeah. I love that explanation. I love her framework. I'm going to butcher it a little bit, the way she puts it in her book, Change Your Diet, Change Your Mind. But basically, it's kind of like the two effects, right? You're eliminating a lot of the foods that are causing harm, a lot of the ultra processed crap and things that are causing inflammation. You're also increasing, by the nature of the thing, the foods that are very nourishing and healthy. And like you mentioned about the brain being made of fat and cholesterol, like that's all part of it. And if you can include those things with the protein, those are the things that end up making the most, benefit for healing.
Yeah, there's a lot that goes into it. She talks a lot about insulin resistance. And so insulin resistance creates an energy crisis in the brain and nervous system tissue, especially. And so the brain winds up effectively starving because it has glucose running around, for example, but it can't use it because with insulin resistance, your brain downregulates how much insulin it lets in to the blood-brain barrier. And so you get all kinds of dysfunction, and part of that is nerve dysfunction, leading or contributing to these things that we mentioned, psychiatric disorders, but also nerve, dysregulation and potentially pain. So there's a lot of things that go into this hormonally, from a neurochemical standpoint, from a mechanical standpoint, inflammation. Again, I don't want to overstate this, but it can help. And then there's the patients that have not necessarily structural disease, but functional disease, and I'll call it that. For example, fibromyalgia, which is not a structural problem, but it's a nervous system dysfunction, and maybe a muscular system dysfunction, or neuropathy from diabetes, neuropathy from chemotherapy, a number of different disorders, MS, which is obviously an autoimmune condition, autoimmune bowel conditions, right? And so, you do the things that we talk about here, real whole foods, mostly animal-based, if not entirely animal-based, depending on the individual. And you see some of those autoimmune phenomenon decrease. You see the direct nerve related conditions like neuropathy from diabetes and chemotherapy, you see them lighten. And so in my mind, there's very few patients that couldn't benefit from at least going partway down the pathway here.
I just learned about a friend of one of my clients who has neuropathy so bad that he couldn't feel that he had like completely broken his foot in like multiple places. And yeah, his diabetes is so bad they had to put it into a boot. And then later on down the road, I just found out like last week they just amputated part of his foot. That's not probably going to get any better. And you hear about how depressed he is. He's just so bummed out about the whole thing that he doesn't do anything. He just sits around. He's only supposed to take like 200 steps a day or whatever. And you realize all of those things just run together. It's crazy how they can all positive spiral and go the other way, but how bad it is when all of them are running together. And you mentioned depression, and knowing what some of the side effects are of depression is weight gain. Like it just makes it so much harder on the mechanical piece that you already talked about.
Yeah, and the diabetes neuropathy is tough because at some point the damage is done. It's irreversible to a degree. But you're right. It's unfortunate. One of my favorite patients in my clinic is one of my worst diabetic neuropathy patients. He's 77, and when I met him, his A1C was about 9.5. He was on 450 units a day of U500 insulin, which is huge doses of insulin. And over about the last 12 months, his A1C is now 6, and he's on 30 or so units of insulin. So he's not off. He's not completely off, but substantially better than he was. His neuropathy is a little better, not like gone by any means, but it's not nearly impacting him the way it used to. He's off his blood pressure drugs. He's down 40 pounds.
Wow.
So, that's a dramatic example, but it's what's possible.
Yeah.
You know what I mean?
That's so amazing. Wow. I love that. Okay. So speaking about that, I want to talk about what you do day to day, because you are in a practice in the medical system. It's not like you're doing, concierge service where you can spend an hour with people. So let's just talk about the practical side of things, and then we'll talk about kind of the response from the patients. But first, like, how are you able to bring this up when I would assume you're very challenged for time when you're meeting with people on a schedule? How are you able to kind of practically get this into somebody's consciousness?
It's difficult. I would love to have an hour with everybody. And so I bring it up every chance I can. I obviously address many of the other things, the interventional options, the medications, or what have you. But I will usually bring it up, either, especially when people have diabetes or metabolic syndrome or weight problems, and I kind of go over a Cliff Notes version of what I generally recommend and why, and then I give them kind of a packet of information. I say, take a look at this. I've got a ton of books and podcasts and resources on there for people to kind of go down and do their own digging and research. I said, bring it back next time, and I want to talk more about it. And so it's little by little, trying to chip away at it. To your point, I can't just sit down and kind of knock it all out in one sitting. Sometimes I just try to get people pointed in the right direction. And then as I see them, over the coming weeks and months, we try to go over it. I had another guy the other day. I was working on him for about 7 months to try essentially mostly a carnivore strategy because he has kind of bad ulcerative colitis. And he finally came in a couple of months ago, and it was funny because it was almost like it was his idea, even though we had been really kind of like, I've been trying to get him on that train for a while.
Good.
And he goes, yeah, I've been doing this carnivore thing. And, my belly pain's better. And we've cut him in half on his opiates now, over time. And it's just kind of funny because he kind of acts like it was his idea, but that's fine. Whatever gets him there. I don't care.
Wow. Oh man, I love that. Okay. So yeah, I realize what a challenge it is to be able to talk about these things. And it's cool that you've been pragmatic and able to give somebody some resources, in whatever way that you can. And, a lot of us learn that way. It's just kind of the long con. It just takes a long time of repeating information until it kind of sticks a little bit. How has that information been received? I mean, heard a lot of awesome success stories. Are these the outliers, or is this what you're seeing with more people than not?
Not everybody's ready for this. So, and not everybody can do it. So, for example, I've got some people that are, really bad metabolic syndrome, but they're living in a nursing home or a assisted living facility, and they don't have control over the things that they're offered from a dietary standpoint. I'm not going to harp on folks like that too much. Or, you sit down and talk to somebody for a while, and you can kind of get a feel for whether or not they are open to talking about this. And sometimes I'll ask them, are you interested in learning a little bit more about this? And sometimes they'll say no, or they're like, you can tell that they're just not ready. It's like quitting smoking. Some people are just, they're not there. So I don't want to browbeat them with that. But I think that, you do the best you can. And on average, the people that buy into it do get benefits. Some people don't. They're a lot more slow to buy into it. And that's one of the drawbacks of what I do, is because the clients that come to me are not expecting to talk about this. The clients that come to a more concierge, low carbohydrate sort of position, especially one that's more primary care oriented or whatnot, they're kind of expecting that. And they're motivated to do that. That's not my folks necessarily all the time. And so, again, I do the best I can with the time that I have. But it's funny because almost nobody in this chronic pain space is thinking about this. I go to national conferences, and there's nobody talking about this. Nothing. And no, so any little bit I can get people in a right direction or better direction with, I'll take it.
Yeah. Wow. When you look generally at your people, as far as like the kind of pushback that you would get or questions that people would have, is it more like they've been indoctrinated by our nutritional guidelines, or they've seen too many Netflix documentaries and they're plant-based, or is it just more that like ultra processed food is freaking delicious and it's really hard to give it up?
I'd say, down here at least, I've got a little bit more of the population that for whatever reason sort of has it in their head that, meat is bad. And that I get a lot of people that say, yeah, I eat pretty healthy. I try to avoid red meat, or things like I got a friend or a relative or whoever that's vegan or swears by low fat strategies and calorie restriction and all these things. And so it's more like a previous dogma sort of thing, or maybe a dietitian that is, from the old training sort of thing, 6 meals a day and 60% from carbohydrates because your brain needs glucose for fuel, which we know is misleading. So I haven't seen it too much from the processed food side, although I did talk to a lady the other day that told me flat out she is straight up addicted, and she was like, I just can't do it. And I said, well, I think we can still try, but I get you. When I talk about that, I say, we don't tell heroin addicts to just have a little heroin, to do it in moderation, but we do that about processed foods and carbohydrates and sugar all the time. So that's kind of what I run into.
Yeah. Okay. That's very enlightening. Yeah. The food addiction piece to all of this is really fascinating. I feel like in your personal story, you kind of came across a little bit of that as well. I feel like I have a little bit of that in myself, not in the way that I, crave it like I used to, but if I start, it's harder for me to stop, and it leads down a path that I don't like. And so you do agree that food addiction, sugar addiction is a real thing.
Totally. And I've struggled with it for years. I am one of these people that if I have one Oreo, I want the whole thing. And there's a lot that goes into that. There's psychological issues. There's sort of habitual issues. There's the addiction piece. There's dopamine reward pieces to it. There's the physiologic, the insulin sort of glucose roller coaster that you put yourself on, and then the guilt and shame that follows. And again, many of the folks that treat food addiction recommend a moderation strategy or permissive strategy. And I'm not trying to refute some of those strategies necessarily, but in my experience, I just haven't seen that be successful because it's hard to stop. It's hard to, and then again, from a physiologic perspective, you're not able to reverse the things that, matter in terms of insulin resistance and all of that either. So yes, it's a real thing. I agree.
Yeah. Okay. Me too. The connection between the brain and the gut we're finding is becoming stronger and stronger. What have you learned as far as like things about the microbiome and the importance of gut health relating to pain itself?
The way I think about the gut microbiome is the more I know or more I learn about it, the more I realize I don't know.
Seriously.
And that's probably true for most of this. And in fact, I have a mentor who used to tell me that that's probably the hallmark of a halfway decent clinician or scientist. So that's another reason I don't want to claim too much about this. I think what is clear is that having a ultra processed food sort of strategy is detrimental. I think what is clear is there is something going on that is incredibly intricate and way more complicated than we really think we understand right now. My biggest beef with this whole field is the idea that we know how to modify it. Whether it's prebiotics, probiotics, fiber, the claims that are being made about that sort of thing, I think are outsized, and I think we need to be really careful because I'm not out here, for example, hawking a supplement line that's $100 a month. I'm not out here telling people to do things that require you to take 20 supplement pills a day or whatnot. And I think that's the trap we get into with some of this gut microbiome and probiotic or whatever sort of arguments. So, but there was really cool studies about people having diabetes and getting stool transplants, and their diabetes got better or went away. Yeah. So there's something here. Yeah. We're barely scratching the surface.
Interesting. Have you seen the latest Netflix documentary that talks about this?
No, I haven't yet.
I think it's called Hack Your Health. I have to watch them every time they come out because I get a million questions about them. So I have to subject
Sure.
myself to whatever nonsense is there. And this one is all about the microbiome. And it wasn't too egregious. Of course, the things that you expect, like it's going to promote the diversity of fruits and vegetables. One expert was saying you need like 20 to 30 different fruits and vegetables and more fiber, obviously making the case that you hear all the time that a more diverse, microbiota is better. Again, whether we can claim that or know that, I don't think we're even in the ballpark of being able to say any of that stuff. They do show fecal transplants and people doing them at home and showing some of that evidence. So I was honestly a little surprised that they went there. That's pretty progressive, I would say. But there was one part I thought was so funny. This one woman, she's a Michelin rated kind of chef. She suffered with orthorexia and anorexia in her life. Mm-hmm. And at one point she's just like, when I think about cravings, like the one thing that I feel like I crave is a big, rare steak. But I kind of want to listen to my body and I just kind of push that thought away. And it's like, no, like you gotta have the steak. That's what your body's telling you.
Yeah. And Sean Baker, Dr. Baker talks about this a lot, where the things that we are supposedly getting from a high fiber or sort of probiotic approach is in meat. And, on the other hand, right, when it comes to fiber, there's evidence in both ways. There's evidence, especially from like the constipation or gut sort of function literature, that higher fiber works for some people, lower fiber works for other people. Again, we don't really know. And that's why I come back to this idea of, first things first, get to a place where we're eating things that don't have an ingredient label on it, right? And I would say most of the credible sort of dietary folks out there would agree with that idea. Whether you're carnivore, vegan, somewhere in the middle, doesn't really matter. I think that that's something we can agree on. And then from there, then the direction that you take is a little bit of nuance and a little bit of which Kool-Aid do you want to drink. But I think if we start there, we're doing pretty well. And again, just like, I don't want to miss the forest for the trees. If I've got somebody that's eating, the way I talk about, and the worst thing that they're doing is a little bit of fruit and broccoli, we're doing fine.
Yeah.
Right.
Yeah.
Let's be honest.
Yeah. Seriously, it's bad out there. We recently talked to an ER nurse. Frankly, I was a little surprised when I asked him kind of about the difference between like chronic cases that he sees versus acute cases that he sees, as far as like what's going into the ER. Is it the neuropathy and, the heart attacks and the poor metabolic health versus like the car accidents and like the trauma that you would expect? He said it's not even close. I thought it would at least like kind of be close. He said it's not even close. It's definitely the metabolically ill. So asking you, when you're dealing with pain, same kind of thing. Like, are you dealing predominantly vast majority of people with these metabolic conditions, or do you also see a lot of people, maybe like yourself, used to be an athlete, injured your knees in college, like acute things that came from like sports or performance, or, types of exercise that were too much?
It's a little bit of both. So part of my practice is more the chronic illness side of things. And then part of my practice is the injury world. So people with car accidents or slip and falls or some other traumatic event. And that's a bit of a whole different ball game. So most of my time is the chronic folks. And, most of what I do is spine related. So people with pinched nerves and arthritis and other conditions of the spine that can generate pain. And then layered on top of it, they've got diabetes or obesity or whatever. And so that's why I think about this from that sort of gas on the fire perspective, where, we've got this one problem here, but we're also making it worse by not addressing your diabetes or your smoking or the weight concerns. In addition to whatever else we're doing.
Yeah. Okay. So for a majority of people, like you said earlier, exercise as we think of it is kind of off the table. If you're already in pain, obviously that's going to be very, very difficult, but to some degree, you must want people moving in some way. Like, how do you think about, like pain reduction as far as the movement side of things goes?
Yeah. I tell people a couple of things. I tell them, do what you can, and let pain be your guide. There's a whole spectrum here. I got some patients who are in their 30s and 40s and, they can do a lot more than some of my other patients. And so, yes, I want them to be active as best they can. But, for example, I have a guy who had a hip fracture and an infection afterwards, and they couldn't replace his hip because of the infection. So they did what's called a girdle stone procedure, where they took his femur, his leg bone, and shoved it into his pelvis. Okay. Trying to tell that guy to do some exercise is insulting.
Wow.
Okay. So yes, he can do some upper body stuff maybe, but the guy's 72 years old. Like, it's just not viable for many of them. So usually what I tell people is at least do the physical therapy type of things that we've done when I've gotten them into physical therapy, maybe some water therapy, maybe, if they can. My favorite thing is resistance training, because muscle is gold when it comes to longevity, when it comes to function, in my opinion. I tend to shy away from the high impact type of exercise like running, or even to a degree biking for some people can be tough. Like swimming, like lap swimming can be tough on the shoulders for a lot of my patients with shoulder problems. But at the end of the day, I want people to do what they can consistently do as much as you can, whether that's a little bit of PT at your house, whether that's, I got some guys that are marathon runners still, but their knees are bothering them, surprise. And, and anywhere in between.
Yeah. Okay. That's really, really helpful. I see those physical therapy sheets floating around all the time for some of my clients who've been to PT, and they've been done exactly 0 times in the history of those generic sheets. Like, it seems like people take them home and never do them ever. I'm still in pain. I wonder why. Like, did you try to read the instructions? Like, try that first.
You've got to go home and do it every day or every other day or whatever it is. And if that's all I get to, fine, whatever. But, people get hung up on this idea of exercise for weight loss. I got bad news for people. It is not on its own very helpful. It's permissive, meaning it will maybe facilitate it. But my opinion is, unless you get, just like calorie restriction, unless you get to a very lean level, if you're a guy and you're 15% body fat and you want to get down to 10 or 12 or something like that, yeah, you're going to have to exercise and you're going to have to calorie restrict. But for most of my patients, they're up in the 30, 40 plus range body fat percentage. And at that level, with that level of metabolic damage, the what and the when of when they eat and the is much, much more important than calories or exercise, in my opinion.
Thank you. Could not agree more. Love that. Okay. In your practice, we mentioned in the introduction, multidisciplinary, you do lots and lots of different things. Obviously the scope of this podcast is more about the metabolic health side of things and nutrition, and exercise and movement, but I do want to give you a little bit of space. Can you talk about some of the other modalities that you use for people that get you the most excited? Most of them have really long names that I can hardly pronounce. So I'm just going to turn it over to you to try to do that.
Yeah. So I'm not going to confuse myself with being a surgeon. But I am a lot closer to that than I am somebody who just uses medications for pain management, like was historically the case in pain management for a long time. And so I do a lot of, for example, people with pinched nerves in their spine and their back. I will do things, obviously the first thing that we do typically is epidural steroid injections, putting a little steroid and numbing medicine around nerves in the back that are pinched. But if that is short term, for example, we can do some minimally invasive decompressions, trimming some of the ligaments that are contributing to pinched nerves, or I'll put spacer devices in to sort of prevent nerves from being pinched. I'll put implantable devices in to manage pain, things like spinal cord stimulation, or subtypes of that called dorsal root ganglion stimulation, peripheral nerve stimulation, targeting peripheral nerves that are affected by pain. I'll do procedures where we deliver opiate pain medications to somebody's spinal cord, and we implant that reservoir underneath the skin. I'll do procedures where we place cement into a vertebra that has been fractured in order to reduce the pain and stabilize the fracture. So again, I am not going to make claims that I am some sort of neurosurgeon from that standpoint, but the field of pain management, the future of pain management is in that direction, somewhere closer to that than not.
Yeah, it's very interesting. If you're seeing somebody for the first time and say to you like, oh, I've done pain management in the past and I've done X, whatever that thing is there anything that somebody says to you these days that like they're doing and you're like, whoa, not great, that's a little archaic, or you're something you're
Yeah.
not really agreeing with?
Yeah. I mean, the big one is opiates.
Yeah.
Right. So, I mean, that's the elephant in the room with pain management. It's gotten much better than 10 or 20 years ago, I would say. The deal with opiates for chronic non-cancer pain is the evidence is terrible, at least oral opiates. And so what I mean by that is most of the studies that we have out there for non-cancer related pain say that whether you're on opiates or not, your pain score and your disability scores are all the same. And so I will have patients who come to me on those medicines. The biggest sort of deal breaker with those medicines is when they're mixed with other dangerous things like alcohol, like benzodiazepines, like Xanax, like illicit drugs, what have you. Obviously, those are non-starters. Those are things that we don't entertain that. And so, but if somebody comes into me and they're not already on an opiate for any reason, 99 times out of 100, I do not start them on one. If they are already on one when I meet them, it depends. If it's a reasonable thing and they think it's helping and we're not having a lot of trouble and we're not worried about how they're taking it, well, maybe we play ball with it while we do other things, right? I never want that to be the only thing that we do. And with the long-term goal of getting off of those medicines as much as possible, because those medicines, just like the statins, have substantial side effect risk. Obviously, everybody worries about death, but many people don't realize that being on the opiate medications for a long time places you at risk for actually a higher sensitivity to pain. So you get more pain with time for some people. Obviously, they can slow your guts down and have constipation. You can have nausea. We worry about how people take them, of course, and there's a risk to my license. There's a risk to having something happen, and the Florida, especially, unfortunately, is a bit of a litigious state. And so you worry about that a little bit.
Yeah, that's so interesting. You mentioned 20 years ago when my mom was going through severe cancer treatments. Obviously, she was prescribed 20 years ago, like the strongest oxy. And I remember one time hearing her say that the doctor told her that if the pain was too intense, she could just chew it so it could fast release. Yeah, the cringe on your face is about what I think about it now. Like, not great. It's not a good idea.
No. I had a guy once tell me, he was like, the medicine works pretty good when I take it, by mouth. But if I crush it up and snort it, it's so much better. God. I'm like, don't tell me that. Oh. So needless to say, we did not really continue that treatment plan. So yeah, and cancer pain's a whole different ballgame. That is the best use for the medicine in addition to surgery. If you have a knee surgery and you're recovering, you're going to need some medicine for a week or two, whatever. But everything else, there's not great evidence for now. Nothing's black and white. Okay. I'm not going to be dogmatic about almost anything I do. And so, I got a guy, for example, I think comes to mind. His hand was crushed in an industrial machine. Okay. And it's mush. He had surgery on it, but it's just mush. There's only so much I can do about him in terms of other therapies. And really, I'm not going to try to tell him that changing his diet is going to be this miracle thing, right? So a guy like that, we might need a little bit of opiates for him for a while. So anyway, like I say, it's very individual. But I, on average, I'm trying to avoid those sorts of things in favor of less risky strategies, procedural options, dietary lifestyle factors. Non-opiate medication.
Cool. Yeah, I really appreciate that. Before we let you go, I want to go back to your personal story. You've referenced several times a carnivore diet. How has that carnivore diet evolved for you? Where are you today as far as the things that you personally eat that you find to be the most beneficial for you?
Yeah, so I think like a lot of us in this space, I started sort of dirty keto, right? I was, eating a lot of keto treats and fat bombs and all kinds of things that I do not consider real food anymore. And slowly over time, I've sort of whittled that down into something that is mostly carnivorous. So a typical day, for example, I might, in the morning, I get up and work out. And so the most processed thing I tend to have is like a whey protein shake in the morning. Because if I try to eat before I work out like a real meal, I'm kind of full and nauseated for a little bit. But then I'll have we usually have like leftover ground beef or steak that I'll cut up and have for lunch. And then like tonight we're going to a Mexican restaurant around the corner where I'll get this literal just big bowl of meat. It's called the fire molcajete, and I just get it. It's got a bunch of meat in it. It's got
awesome.
a little bit of it's got a little bit of like onions and peppers, but whatever. That's not a big deal for me. And some cheese on it, and that's perfect. Again, I'm not dogmatic about this. The people that may need to be more dogmatic, like autoimmune conditions, like irritable or inflammatory bowel disease, they may be sensitive to some of these things, but personally, I'm not. I incorporate maybe a little bit of fruit or honey here and there, but again, I got to be careful with that because personally, sometimes it is a bit of a trigger for me to eat more sugary things. So I'm careful, but a lot of people tolerate leafy vegetables just fine. I think that's okay. And I'm a decently active person, but I find that I don't necessarily do any better when I incorporate more starches into my diet. I don't feel any better in terms of workouts. My mental clarity is better when I don't have them. I will periodically fast a little bit, whether it's time restricted eating, 16, 18 hours. Once in a blue moon, I'll do a 24-hour fast, but not every week, not all the time. And so I was listening to Dr. Georgia E the other day again, and she talks about her journey, and she's kind of gone through a number of spectrums of things. And I think that's totally natural to sort of ebb and flow a little bit in and out with what we do. And there's not one right thing for anybody. I don't think either.
I love that. I don't know how much time you spend in the carnivore community, but it just kind of seems like this idea kind of comes and goes every few months. But like, if you're not 100% carnivore, then you're not carnivore, and we need to call it something different, like animal based or whatever. Right. And I as much as I've hosted people on the show that claim that, and as much as I understand, and we all need to kind of tell people like, this doesn't mean you have to be 100% strict. I wish we didn't have to like go there and try to say that there's a difference between being carnivore or mostly carnivore, animal based or meat, whatever you want to call it. Like, it means that the same kind of definition in nature. A majority of your calories are coming from animal foods. You go out and you find whatever plant foods that you can eat seasonally. I agree with you 100% with the fruit. For me personally, like, can I have fruit? Is it going to make me fat? Like, no, but I have cravings. It makes me really, really hungry in 20 minutes. Like, it's not the worst, but I don't prefer it. So I like you, I have to be careful with it. But I really want our message to be inclusive for people to come in this direction. Whatever it is for you, nobody's going to, tell you that you're not doing a carnivore diet if you slip once in a while or include things regularly. You know what I mean? I think it's annoying.
Right. And I think we're missing the forest for the trees again with that. We don't need to be, talking, or arguing about the semantics of this stuff. I think that, again, if we're getting to a place where we are eating real whole foods that don't have a whole lot of ingredient labels to them, like we're doing fine, whether that's pure, carnivore, based on what the sort of the zealots think, or not. And, if you think about our human species, we were not pure carnivores. Let's be honest with ourselves. We were omnivorous. Okay. So let's not get too carried away with this. It's just that some people may do better with a little bit of plant matter or not, or a little bit of fruit or not. And it probably, if we're being really sort of scientific about it, it probably was seasonal, right? If you were really going to try to mimic what we used to do in our ancestry, depending on where you lived in the latitude that you lived in and the part of the world, our diet probably changed throughout the year to a degree. So, and I don't want to speculate too much on what happened 1,000 years ago, but, I don't want to get down and lost in the weeds and the minutia with people about that, because it's not useful for the vast majority of people.
Yeah. Before we go after you for eating onions and peppers and your delicious molcajete, like take a trip to Costco where all of the handicap places are taken. Tons of people are zipping around in scooters, and you look at the disasters in some of these people's carts that are really not doing great. Like, I think we should address that before we worried about your grilled onions and peppers.
Right. Exactly. And there's some folks in the carnivore space who I really respect. Don't get me wrong. They're doing great work, but like, for example, if the worst thing somebody's doing is drinking out of a plastic water bottle because they're at an airport, fine. Like, it's okay. That's not going to break the bank. If the worst thing we're doing is some cruciferous things here and there, or, exposed to Wi-Fi, you know what I mean? Like, let's just, if you try to make that your message, you're going to lose a lot of people. Yep. Because it's not achievable.
Yep. Agree.
That's all.
Agree. I love that. That's not the hill we're going to die on around here. Man, no. Dr. Netzel, this has been an amazing discussion. I've been looking forward to this for quite a while. And like I said earlier, like, I don't see many people making these connections between diet, metabolic health, and pain management. So I think your message is really, really valuable for a lot of people out there. Where can people go to find you and connect with you and your work?
So I'm in Jacksonville, Florida, part of Coastal Health. And then on Instagram, I'm at Keto Pain Doc. And so, I'm happy to either be on one of those two platforms for people. I don't really do much on Facebook anymore. I don't really know why, but I just haven't been on there in a while. Me and social media are kind of love-hate a little bit. So I it's useful to me sometimes, but I don't, I get sick of it every now and then. So, but, Instagram is probably the quickest one.
Yeah, gotcha. It's primarily helpful for watching Formula One videos and NHL highlights. That's about it. I recommend.
That's right.
Yeah, or fights on Twitter if you want. That's fine too.
That's right.
Dr. Netzel, again, this has been an amazing conversation. I really like the way you approach things. And thank you so very much for all of your work and taking time to be on our show today. We really appreciate you.
Happy to be here. It's been an honor. Thank you for having me.
Oh, such an honor to host you. And this has been another episode of Boundless Body Radio. Thank you so very much for listening to and supporting Boundless Body Radio. This podcast is such a passion of mine, one of my favorite parts about running our business, and none of this would be possible without our incredible guests and listeners like yourself. Thank you so very much for all of the amazing reviews that we get on Apple and Spotify. Trust me, we read them all, and it means the world to hear that you are enjoying the show as well. I am very excited to announce that this summer I will be hosting a nutrition seminar series. This is actually a project that I started after I became certified as a nutrition coach. I wanted to get a group of people together to discuss all aspects of human nutrition, and as a bonus, I did the whole thing outside by a pool, which was great. After the pandemic, I stopped hosting the series, but this year I've decided to bring it back. Each week, we'll have a particular topic and an agenda. We'll have outlines that include references, and also meal plans, guest appearances, book giveaways, and more, all for free. For those of you who live in the Salt Lake City area, the seminars will be hosted every Tuesday at noon, starting on May 28th, and will run all the way until September 3rd. The seminar will be hosted outside, of course, at the beautiful Bowery Park in Daybreak, where I live. If you're available and in the area, we would absolutely love to see you there. If you are unable to attend, either that day and time does not work for you, or you don't live in the area, good news for you as well, we are going to put all the recordings and post them on YouTube, where you can submit listener questions in the comment section, which we can address in future seminars. I'm also including all of the seminar materials on our website, so you don't have to miss out on the content. My goal is to make a comprehensive yet simple understanding of nutrition so that anybody confused about how they should eat can create a framework for themselves based on their individual goals. As I said, if you're interested in participating, we'd love to have you. If you can't make it into the in-person seminar, be sure to subscribe to our YouTube channel and also our website at myboundlessbody.com/seminar to find all of the resources, videos, and a fun quiz. Either way, thank you as always for listening to Boundless Body Radio.